Yeah, good evening all. So we have today with us Dr. Anshu Agarwal and Dr. Prakash. We are going to discuss imaging in femoroacetabular impingement, today's topic. We have with us Dr. Prakash. He is a senior orthopedic surgeon, a senior consultant and head of the department at the Star Hospitals, Hyderabad. And Dr. Prakash has done F.R.C.S. And in London, and is my close friend first. And he's previously worked in Yashoda hospitals and care hospitals, and he's a guest speaker in many prestigious conferences across India and abroad. And is panelist and moderator for many conferences and so many presentations to the credit. And special interests are in the in shoulder, knee, and hip related conditions. And one more, our radiologist, Dr. Anshu Agarwal, he is a consultant radiologist at our Kolkata-based Vijaya Diagnostic Center, and is so much interested in musculoskeletal imaging, and is initially, I want some comments from Dr. Prakash about femoroacetabular impingement and how it is useful, like imaging is useful to come to a conclusion about the diagnosis, because even normally we find this kind of imaging appearances in normal individuals also, but when clinically you recommend to look for femoroacetabular impingement. Just wanted your ideas.
Thank you, Dr. Krishna, Mohan, and Dr. Anshu. Thanks for giving me this opportunity to interact with so many experienced radiologists. Yeah, femoroacetabular impingement is not an uncommon condition actually. In the past, maybe 2 decades ago, we didn't know much about it clinically. Although the radiological findings were there in some people, nobody knew exactly what it exactly meant and how it sort of translates to the clinical this thing. However, of late we have increasingly observed that majority of patients with femoroacetabular impingement can develop labral tears, and especially with the cam and pincer type of impingements, they can over a period of time develop osteoarthritis in the future. So these are the 2-3 things that we have observed over the years, and a lot of interventions in the form of physiotherapy, injections, surgically. Anyway, we can discuss about them in a little later. But in a nutshell, a lot of patients who did not have a diagnosis in the past for the deep joint pain, which did not show any evidence of arthritis on the plain X-rays or MRIs, now are being picked up as having some forms of impingement. And that is very important actually for us to identify as clinicians. Radiologists help in diagnosing these conditions, because clinically a lot of similarities are there between this and osteoarthritis. Only radiological imaging can help the clinicians better. So I would love to hear further from the radiologist to improve my understanding of the radiological anatomy of the impingement. Thank you.
Yeah, Dr. You can start your presentation, then we can discuss on it.
Okay. First of all, I would like to thank Krishna Mohan sir and Veda sir in giving me this opportunity. And after the brief discussion of Veda sir, I feel again like I'm standing in that examination of my final year and giving some, viva to a very renowned senior consultant. So I hope the presentation goes well and I add up to the clinician's diagnosis for femoroacetabular impingement. So, it's a very complicated topic, and diagnosis sometimes is usually most of the times is usually with the help of the clinicians, and they guide us that what they want actually. And in this topic, I will discuss about the pathomechanics and types of femoroacetabular impingement. So first, let me give a brief description about what are the clinical presentations usually. So they present with motion or position-related hip and groin pain. Example, a painfully restricted range of motion during hip flexion, internal rotation, and adduction. Sometimes the pain is also described in the buttocks, backs, or thigh, and in addition, there may be symptoms of stiffness, clicking, locking, or catching. A common test which is done is called FADER, is flexion, adduction, and internal rotation test. It is sensitive but not very specific. So, what is the motive? What is the motivation behind diagnosing this? So, this is an X-ray of a young adult with a cam deformity. Right now, this patient is not having any osteoarthritis changes. But if this patient is left untreated, the second X-ray which is showing, it shows that the patient has developed severe osteoarthritic changes and now things become difficult. So if early diagnosed, we can help the patient from getting into severe osteoarthritic changes, which might be very difficult to treat. So basically, we have two types of femoroacetabular impingement, cam type and pincer type. Now, cam deformity has come from camshaft. So it is basically an overgrowth of the or an osseous bump in the femoral head neck junction, which coincides with the acetabular labrum and causes damage. And pincer is basically the overgrowth of the acetabular labrum, which restricts the movement of the head of the femur. So, if in a layman language I try to make you understand, when a wooden door, it kinds of increases in size, and we try to shut it down, it gets stuck with the edges. And in pincer, say like a car, a tire of the car, when there's too much of mud or snow gets attached to the edges, it restricts the tire from moving smoothly. So let's have a look at the cam lesion. So now this is an X-ray AP view, in which we can see there is an osseous bump on the femoral head neck junction, and this osseous bump, when there is an
So we're not able to see your X-ray.
See the X-ray, yeah.
oh, sorry.
Right. Yeah. Sure.
So this osseous bump, when there's extreme of flexion or adduction, the bony bump will collide with the acetabular labrum, and and ultimately it will lead to injury of the labrum, acetabular rim. Not only the acetabular rim gets damaged, but also there are also there are surrounding structures like cartilage and labrum, which experience a shearing force, and ultimately they get damaged and will produce crack at the chondrolateral junction. Now, how do we now? What is abnormal offset? So the head and neck junction has an S-shaped curved usually in a normal patient. Now, if you draw an imaginary line along that S-shaped curve, anything which is above that S-shaped curve is called an offset. That's an abnormal offset or an osseous bump. Now we use an alpha angle to measure what could be the angle at which the deformity is there. We draw a best fit circle, and then we draw a straight line along the head and neck junction, and then we draw another line joining the head and neck, joining the straight line from the superior part of from where the bump starts. Now, if this alpha angle is more than 55 degree, it means that it has a high significance that this osseous bump will cause damage to the acetabular labrum. Now, this is a classical example of a patient with cam deformity, and we can see that there is a anterosuperior labral tear with a small, tiny paralabral cyst, which ultimately happened because of the cam lesion. And we can see there is a small area of cartilage loss appearing hypointense on T288 sequence in the anterosuperior region of the acetabulum. Next, we come to pincer and dysplasia. So what is pincer? As we have already seen, that pincer deformity is basically overcoverage of the acetabulum. Now, how do we measure pincer deformity? we take a best fit circle in the head of the femur, and we use a lateral central edge angle method, in which we draw a straight line along the head of the humerus, and then we draw another line which collides with the anterior part of the acetabulum. Now, if that angle is more than 40 degree, this suggests that there is over coverage of the acetabulum, and if that angle is less than 20 degree, it suggests that it is under coverage of the acetabulum, and maybe some acetabular dysplasia is there. Now, what is coxa profunda and acetabular protuso associated with pincer lesion? Coxa, both of them are deep-seated pockets of the acetabulum. Now, how to differentiate both of them? In coxa profunda, we can see there is a ilioischial line, sclerotic line, which goes to the medial margin of the acetabulum. Now, if the medial margin of the acetabulum is very closely related to the ischioilial line, or it is crossing that line and going medial to it, then it is called coxa profunda. It's a deep-seated acetabulum. And if the head of the humerus is crossing it medially, then that is called an acetabular protrusion or protuso acetabuli. Now, again, another example of pincer lesion can be cephalhead acetabular retroversion. Now, it is basically the anterior wall is prominent than the posterior wall of the acetabulum. And in extreme flexion, what happens is that the head and neck junction will again collide with the anterior wall of the acetabulum and again produce damage of the anterior part, leading to labral tear and chondral defects. So, how do we assess that it's a cephalhead acetabular retroversion? Now, the anterior and posterior wall of the acetabulum, they never cross each other. But in this condition, if we draw an imaginary line through the anterior wall and the posterior wall, we will see that they both are crossing each other and producing a crossover sign and an imaginary figure of 8 sign. So, this is a cephalhead acetabular retroversion. Now, some examples of labral tear, though I'm not going in deep because it's a altogether different topic. Labral tears can be classified by the location morphology. With respect to the location, tears are usually classified as anterior, posterior, and superior lateral tears. Labral tears can be classified morphologically as radial flap, radial fibrillated, longitudinal, peripheral, and unstable tear. Radial flap tears and radial fibrillated tears involve the free margin of the labrum and are most frequently encountered. Longitudinal peripheral tears of various lengths are seen at the acetabulum labral junction. Unstable tears follow no real pattern but they are usually associated with mechanical symptoms. Now let's see some example of the labral tears. Now this is a 57-year-old female with right groin pain for 2 months and no relief after with intra-articular steroids, and there was an arthrogram done. We can see the contrast going through the labral cartilage junction representing a tear. You can see the contrast is going through and through the labral cartilage junction, and the labral is torn with this, and there's loss of that normal triangular pattern of the labrum. The torn part also has irregular margin. This is another example of a patient who had tear while playing soccer, and there's a posterolateral tear with capsular tear and avulsion. Now, acetabular dysplasia. Now, again, acetabular dysplasia is again we use that central lateral edge method to see the degree. If it is less than 20, it suggests that the acetabulum dysplasia is there, and it's a short acetabulum. So, what is the problem is that when there is weight bearing, the acetabulum is not able to hold the femur, and the femur again collides with the short labrum which is there in the anterior part, and which on continuous shear forces leads to the tear of the labrum. With this, what happens is that the ligamentum teres, which which tries to restrict the head of the femur from going out of the acetabulum, it becomes hypertrophied, and in some cases, as we can see, there's a tear in the ligamentum teres also. Now again, we can see the patient. In this patient, we can see there is a chondral defect in the superior aspect of the femoral head, and this is a delamination of the chondrum or a carpet lesion of the acetabulum. In this second image, we can see there is a small tear in the anterosuperior part of the labrum. Now, there are a few normal pathological variants which are usually seen and may be associated with femoral acetabular impingement, like synovial herniation cyst. Now, it is usually seen in the anterolateral femoral neck junction. It is a well-defined round-shaped lesion with low T2 and high low T1 and high T2 signal intensities. Uh, Usually, some intralesional fat is seen in the pits, and adjacent marrow edema may be there or may not be there. Initially, it was thought that these are incidental finding, but with as we went deep into femoral FAI, we found that they have a very strong association with FAI. Second, we come to os acetabuli or chronic acetabular rim fracture, or which is by which it is known now. So, due to continuous injury of a camp or pincer deformity, there is non-union of the accessory ossicles, or a fracture which has become non-union. The issue is that it produces instability due to dysplasia of the hip, as the labral and the cartilage are attached to the os acetabulum, and continuous injury can lead to injury to them. Now, this is a supraacetabular fossa. It is a very normal variant, and it should not be mistaken as a cyst or a defect. It is usually seen in the central 12 o'clock position, and it is usually filled with cartilage. And then this is a posterior-superior or posterior-inferior sublabral sulcus. Now, this is not a tear, as we can see that it is not going through and through of the sulcus, and there's some cartilage left behind, so it should not be mistaken as a tear. It's a very normal anatomical finding which is there. Now, radiographic techniques which are used are AP pelvis view, AP view, false pelvis view, Dunn's view, and a cross table view in X-rays. We try to take most of the maximum X-rays to get the maximum information. There are multiple external impingement syndromes which are there, like iliopsoas, snapping hip syndrome, greater traumatic pain syndrome, ischiofemoral impingement, and subspine impingement, which are also there. So, thank you so much.
Yeah, thank you, Dr. Anshu, for a very nice and very crisp presentation on the FEI topic. So, Dr. Prakash, any comments on the?
Yeah. Thanks for the nice presentation. Actually, the couple of things, the normal variants and how to differentiate from the labral tear. I think that's very important. What happens in these cases is, especially, I mean, the similar thing goes with the meniscal tears and labral tears in the shoulder and on the hip. What happens is, for the clinicians, we get only the films, and amongst the films, you may not have all the cuts. So it is very difficult for the clinicians with a film in the hand to see whether it is thrown through or it is just like a sulcus kind of thing. So something that we rely very heavily on the radiologist report only. So this is so I think the reporting and awareness of the radiologists about these conditions is something that is very important. Second aspect I wanted to ask you people was that how, I mean, when you go back and look at these MRIs which were done for FAS, and most often we may ask for an arthrogram sometimes in these patients, hip arthrogram. So how much percentage of cases you think will be missed if you do not do an arthrogram? I mean, are there cases where you would see them only when you do an arthrogram, or is it possible for you to see in a plain MRI with a high quality MRI? Just wanted an opinion, from the radiologist group.
Yeah, I think 3 Tesla MRI with very high resolution imaging, we can detect the labral tears very clearly with 3 Tesla. Other than that, if the quality of the MR is not good, I think we have to go for an MR arthrogram. But with 3 Tesla available MRIs, we can see the chondral lesions and chondrolabral tears and labral detachments. Those I think we can see 3 Tesla. But we have to be dedicatedly. We have to try to see those things. Like just that we cannot see. But dedicatedly, we have to think that there is an FAI and we have to look for a labral thing and all that.
Sure. I mean, will the sequences be a little different, or will the cuts be much more, thinner? Would you be doing any different sequences or thinner cuts because I wanted to ask it from our perspective that, instead of just saying MRI hip, if the clinician specifically asks this question, would you be doing anything slightly different to pick up that pertinent clinical question that is asked?
Yes, high resolution 3D volume sequence we have to do for a special hip, like a separate hip we have to do. Right side hip and left side hip separately we have to do. That 3D high resolution images we have to acquire, and we have to study for the labral test, definitely. So otherwise, if we do only an entire hip at one go, then the resolution won't be that high. Definitely, like a entire pelvis we study usually when we do hip joints. So then the resolution may not be adequate to study the labrum usually. So we definitely do some dedicated hip MRI. Yeah. So specifically for that hip, that's the specific hip which we wanted, some clinical concern. So
So it is always better from the clinician's perspective.
Yeah, Anshu. Yeah, please.
We take a low FOV. View if there's a high suspicion of FAI. Then a low FOV view gives us a zoomed image and in a thin slice. It gives a very good resolution to see the detailed anatomy of the labrum and the condyle.
Okay, got it. Low FOV. Yeah. Okay. Thank you.
Small FOV. Small FOV.
Small FOV.
Small FOV. Yeah.
Small FOV. Yes. Anyway, small FOV things will be more high resolution usually. If we try to see a larger area in one scan, then the resolution will fall down and we cannot see these tiny structures like labrums and small ligamentous structures and all that. So this applies even for ankle and these areas also. If we try to include entire foot and do the ankle, then the resolution is not enough to see these small ligaments, ATFL, CFL, other ligaments. Same applies to this also. For that matter, any area. If we have to look for some ligament, then we have to specifically study the thumb only, not the entire hand. So yeah, so definitely.
Okay. So any other questions from the...
Yeah, chart. Yeah, we don't have specific questions in chat. So Dr. Anshu, like in case of cam deformity, you find basically tears in which labrum, anterosuperior or?
So mostly it's anterosuperior.
So anterosuperior labrum, right? So in the pincer it is posterior-inferior, right?
Pincer is posterior-inferior and cam it is anterosuperior. Because the cam deformity itself goes and causes shearing force on the anterosuperior labrum.
Right. So in the pincer, we have to look at predominantly towards posterior-inferior kind of the labrum. Posterior-inferior part of the labrum. So how to distinguish this herniation pit from the lesions, like why that herniation pit? Herniation pit. You showed the herniation pit, no?
Herniation pit, yeah.
position pit. It's normal variant, right?
Yes, sir. So it's usually because of the position. At that position, usually we see those herniation pits, and there's usually no edema associated with it. It's a very well-defined round-shaped lesion specifically at that location. And in any other lesion, there is usually some associated edema, but in this, there is usually no edema.
Okay.
In the Asian pit, there is no edema, right? Dr. Ved, like what do you do if you find any of these lesions like CAM or pincer kind of a lesions, if you pick up very early age, like 20 or 30 years, to prevent further degeneration or progressing to osteoarthritis and all that? Do you do
Yes.
any procedures or just a conservative management? Or?
Yeah. So, as I was saying, in the last 2 decades, the outlook of orthopedic surgeons towards FAI has changed dramatically. There was initial neglect, 2 decades ago, and then followed by a huge enthusiasm to do many things actually, suddenly, because people were able to diagnose so many things to the point that about 15 years ago, there was a big time hip surgeon in England he was a hip replacement surgeon, and his talk wherever he goes was that never do a hip replacement. That was his talk. Instead, prevent hip osteoarthritis. So that was his second slide. The first slide was never do a total hip replacement. The second slide was instead try to prevent hip arthritis. So that's how it is. So certainly there was a huge enthusiasm in the earlier days, thinking that if you majority of patients who develop these cam and pincers, who have cams and pincers, will be the ones who will develop arthritis in the future. Especially given the fact that in the Western society, the osteoarthritis prevalence in the hip and knee is entirely different to what is happening in the Asian people. In Asians, we hardly ever see any primary osteoarthritis of the hip. Very rare to see. Any osteoarthritis of hip is usually secondary to either AVN or a trauma or some infection, some such thing like that usually, or childhood conditions like Perthes, slip disc F.R.C.S. Some pre-existing condition will lead to secondary osteoarthritis of hip. Whereas knee joint is primary knee osteoarthritis in majority of cases in Asian population. Whereas in the West, primary osteoarthritis of hip is very common. Much more than, until 10 years ago, there were more total hip replacements done per year compared to total knee replacements. Until this obesity epidemic caught up in the West. Once the obesity epidemic caught up, the knee arthritis has started to sort of cross over the hip arthritis. But primary hip is very common. So they couldn't figure out as to why. But because in Indians also, we try to understand why we develop medial compartment, whereas osteoarthritis in many people. And one of the postulated hypotheses is that probably because of low calcium, low vitamin D from the early childhood, most of us have bow legs to begin with, and then that increases the wear and tear on the medial side, and we develop predominantly medial compartment osteoarthritis. So similarly, they have postulated that these labral tear is a consequence of one of these kinds of impingements, either pincer or cam. So the postulation was that either the pincer or cam will lead to the labral tear, which will lead to erosion of cartilage over a period of time and secondary osteoarthritis. So initially, the enthusiasm was to address the primary lesion, which is either cam or pincer, and then address the secondary lesion, which is the labral tear, which causes pain. So when there is a painful labral tear, in spite of good physiotherapy and activity modification, if the pain continues to be there, there is a certain indication to go in and do about that symptomatic labral tear, whether it is in the form of arthroscopic debridement, arthroscopic repair, or open debridement or repair by way of safe surgical dislocation. So these are the methods that can be employed for symptomatic labral tears. And in symptomatic labral tears, there is a common consensus because the patient is having pain and there is a pathology, and then by rectifying pathology, the pain can be reduced. But when it comes to the first question, whether by doing something to maybe asymptomatic or maybe very mildly symptomatic cam and pincer, will we be able to avoid osteoarthritis in the future? This is similar to what happens in knee joint osteoarthritis, where if you have a grossly varus or valgus knee in the early, late childhood or early adulthood, we do osteotomies in the femur or tibia to make the mechanical axis straight to prevent early osteoarthritis in the future. We do high tibial osteotomies, valgus osteotomies in the knee, and all those things. So similarly, by taking out the cam and pincer, whether we will be able to prevent the osteoarthritis is a major question. People have tried in large volume centers, and there are a lot of studies that are happening, but still the longest follow-ups are around 5 to 10 years of time, which is not enough to see the cause and effect relationship until now. So surgeons are continuing to do these operations because it makes sense. Technically it makes sense. You are actually taking away two abnormal articulating areas so that you do not cause further damage to the labrum. But whether it will translate to the clinical outcomes is something that we'll have to wait and see. The short answer is we do not know by doing these cam and pincer surgeries whether osteoarthritis can be prevented significantly or not. However, for the symptomatic labral tear, which is not reduced with other methods, surgical intervention in the way of debridement or repair, either arthroscopic or open, is a valid treatment protocol.
So symptomatic hips you can treat, but asymptomatic just routine findings on hip joints which are done for some other reasons. So if you find cam or pincer lesions, I don't think.
Yeah, I mean the consensus is not still clear on those, whether by doing something you will prevent arthritis or not. Yes.
Oh, okay. Yeah. So that's a big thing. Like if we think that whether it is really a cause for the particular patient symptoms in the particular case, I think maybe clinical examination should only tell, right?
That is another important aspect that you brought out actually. As I said, the deep groin pain, the hip pain, the anterior groin pain is a very difficult condition to diagnose sometimes. The pathology that we may identify on the MRI may be an incidental pathology to something else that is going on in the patient, including higher level lumbar disc prolapses, hernias, there are many things, muscle strains, rectus tendinitis. There are so many things, iliofemoral ligament sprain, there are so many other things. So in my practice, if there is a labral tear and the patient is having symptoms, I would always go for an intraarticular injection, image guided injection first, intraarticular injection of a local anesthetic and a steroid, and then see how those whether the symptoms will go away or not, even if it is very temporarily. Like if you add bupropion and do something, if the patient's typical symptoms go away, when you do the Faber test, when you do the abduction external rotation, if the patient's pain gets better after instilling local anesthetic into the joint, then that constitutes much stronger indication to go in and do something about that condition. But if that is negative, then I would be very cautious in doing anything for these patients. If you have an image guided, the contrast guided intraarticular injection, which does not relieve the pain at all for the patient, then these findings have to be considered as non-contributory to the symptoms.
Incidental findings, yeah.
Incidental, yes.
Right. Yeah, thank you, Dr. Prakash. Thank you.
Thank you.
Great in clinical inputs. Like we don't know all these things basically. So whoever really see this presentation afterwards, I think they can really learn about FAI and its clinical implications and the treatment, mode of treatment, and all that. At Anshu, excellent presentation. You brought out so many things now, like
yes,
a normal.
Yeah,
thank you so much.
It was a nice presentation. I learned a lot of things. Yeah, thank you.
Thank you, sir. We learned from you, sir. Thank you.
Thank you.
Presentation. Thank you so much.